Hey, what's up, guys? This is Sank Med. I am starting my internal medicine residency in a couple months, and I'm trying to cover some topics every day. So today I'm going to be covering acute coronary syndrome, otherwise referred to as ACS. This heavily references the MGH guide, but I wrote it in a way that it's easily digestible. So let's get right into it. So the first thing to differentiate is this myocardial injury, ischemia, or infarction. So myocardial injury is defined as any patient with a troponin greater than 99 percentile without evidence of myocardial ischemia, may be acute or chronic, just means that the heart is damaged and is resulting in elevated troponins. So myocardial ischemia, it's important to work that up. So the evidence that there is ischemia is if there's any symptoms of ischemia discussed previously in the chest pain video, new ischemic ECG changes, which were also discussed in the EKG video, any wall motion abnormalities, any acute coronary thrombus on angiography. And then myocardial infarction is defined as myocardial necrosis with troponin greater than 99 percentile with significant change over time and with ischemia. So it's important to know the 5 types of myocardial infarction. This will dictate the management and treatment. So type 1 MI is caused by atherothrombotic plaque rupture or erosion leading to coronary thrombus. This is from most commonly like an infarction to the left anterior descending artery. And type 2 MI is due to oxygen supply demand imbalance not related to the acute thrombosis. For example, anemia, arrhythmia, or hypotension. Other causes include sepsis, infection, renal failure, surgery, hypertension, and heart failure. Also vasospasm, Takotsubo, cardiomyopathy, thromboembolism. 50 to 70% of patients have obstructive coronary artery disease as a prerequisite. And for this one, it's important to reverse whatever cause is causing the myocardial infarction. It's reasonable to start an aspirin, beta blocker, and high intensity statin. Type 3 MI is sudden cardiac death with ischemic symptoms or ECG changes before cardiac markers become detectable. Important management for this is the ACLS workup. Type 4 MI is PCI related myocardial infarction, including 4A, which is less than or equal to 48 hours, 4B, which is strength thrombosis, and 4C, which is restenosis. Type 5 MI occurs in relation to CABG, defined by marked troponin elevation greater than 10 times the 99th percentile limit. So now let's talk about evaluation of chest pain with troponin. So say the patient is in the emergency department and the chest pain onset is greater than or equal to 3 hours prior to arrival. The first thing you do is check the high sensitivity troponins immediately and at 1 hour. You can rule ACS in if the troponin is greater than or equal to 52 or increase greater than or equal to 5 from baseline. You can rule out ACS if troponin is less than 10 for women and less than 12 for men, and change less than 3 from baseline. So if the patient is inpatient or in the emergency department and the chest pain onset is less than 3 hours, you check troponin immediately and at 3 hours. You can rule in ACS if troponin is greater than or equal to 10 for women and greater than or equal to 15 for men, and the 3-hour delta is greater than or equal to 7 from baseline, and there are symptoms or ECG changes or concerning imaging such as CTA or cath. You can rule out ACS if no significant changes in 3 hours. If there's intermediate risk, you can calculate the heart score. This is a calculator on MD Calc. You can repeat the troponin in 3 hours and apply inpatient criteria. So let's talk about the different types of ACS. So there's STEMI versus NSTEMI versus UA. So let's talk about STEMI. So for STEMI, any of these criteria match the criteria for STEMI. So if you have one or more of these criteria, it's probably STEMI. So if you have a 1 millimeter ST elevation and 2 contiguous leads, if it's V2 to V3, it needs a greater than 2.5 millimeters increase. in men less than 40, a 2 millimeter increase in men greater than 40, and 1.5 millimeters in women. Or there's new signs of left bundle branch block and positive biomarkers. If they have a baseline left bundle branch block, you can use the Scarbosa's criteria, which is greater than or equal to 1 millimeter concordant ST elevation, 1 millimeter standard deviation in V1 to V3, or a greater than or equal to 5 millimeters discordant ST elevation. Concordant ST elevation basically means that the QRS wave is going the same direction as the ST elevation. Discordant means they're going opposite ways. So if they're electrically silent, it can still be STEMI if it's left circumflex or right coronary artery lesions. You can consider the posterior V7 through V9 leads if you're suspicious, and this will show an ST elevation greater than 0.5 millimeters. Other changes are large R waves in V2, V3, and ST depression in anterior leads. So let's talk about NSTEMI. NSTEMI, there's a positive ECG will show that there's ST depressions, T wave inversions, flattened T waves, and up to 1/3 of them will have a normal ECG or history with positive troponins. So in NSTEMI, you can have a negative EKG, but have positive troponins, in which case it still needs to be worked up. In unstable angina, you will have positive ECG, but there will be negative biomarkers. So, and the biomarkers remain normal after serial measurement. So, for clinical evaluation risk stratification, you will consider the patient's baseline coronary artery disease risk. There's a ASCVD risk calculator that you can calculate to see what the patient's likelihood of having a major adverse cardiovascular event in the next 10 years. And if it's past a certain number, let me just find out. So if it's greater than 20%, then you work them up for inpatient management and more invasive treatment. But otherwise, you review their prior stress tests and cath data, any increase of risk of MI with respiratory infections such as flu, and you treat any secondary causes of increased myocardial demand. So for the ECG, if it's normal, you obtain ECG immediately, and then obtain serial tracings for 1 to 2 hours every 15 to 30 minutes if the initial ECG is non-diagnostic. Findings that aren't evident of ischemia is greater than or equal to 5.5 millimeters ST depression, any new T wave inversions greater than or equal to 1 millimeter, or normalization of prior T wave inversion. So let's talk about cardiac biomarkers. So a troponin greater than 15 nanograms per liter for women and 10 nanograms per liter for men is significant. 75% of healthy individuals have measurable troponin. The important thing to measure is the delta, or how much the troponin changes over time. In the event of a myocardial infarction, the troponin will peak within 12 to 48 hours and normalizes in 5 to 14 days. So for revascularization, this is the primary treatment if you have a myocardial infarction. For STEMI, primary PCI, otherwise known as PPCI, is a recommended revascularization strategy for patients with STEMI less than 48 hours after symptom onset. The door to balloon time should be less than 1 hour. PPCI, regardless of symptom onset, if they have cardiogenic shock, malignant arrhythmia, such as recurrent sustained VT or VFib, or persistent ST elevation and or chest pain. PPCI if greater than 48 hours and symptom onset, not indicated in stable patients. If PPCI is not possible within 2 hours from the first medical contact and less than 24 hours after symptom onset, use fibrinolysis. Aim less than 10 minutes to lytic bolus with immediate transfer to PCI center. Discuss the antithrombotic therapy with cardiology. This is contraindicated in increased bleeding risk, suspected dissection, ischemic stroke less than 3 months prior, or severe hypertension. Basically, if you give antithrombotic medication to someone that has increased likelihood of bleeding, they can bleed from that nidus and it could be a catastrophic event. So for NSTEMI, there's multiple risk models that you'll have to incorporate, such as GRACE or TIMI. The GRACE score is based on predictors of 6 months of mortality. There's 4 subgroups for urgency to revascularization. There's the very high risk group, in which there's immediate invasive therapy within 2 hours is necessary. This is any refractory or recurrent angina, any hemodynamic or electrical instability, any mechanical complications, any recurrent dynamic ECG changes suggestive of ischemia. Then there's the high risk group. Within 24 hours, invasive therapy must be done. This includes temporal change in troponin, such as the delta that I previously talked about, or ECG changes, including transient ST elevation, ST depression, or T-wave inversion. And a high-risk patient is one that has a GRACE score greater than 140. Intermediate risk is the next group, in which delayed invasive therapy within 72 hours is indicated. They have none of the above criteria that was previously mentioned, but risk factors at baseline, including ejection fraction less than 40% and GFR less than 60. And the next group is a low-risk group, in which there's ischemia-guided therapy but no cath, in which there's no risk factors. The GRACE score is less than 109. TIMI is 0 to 1, or the patient is not a good candidate for angiography. So the difference of revascularization, so there's PCI versus CABG. PCI is minimally invasive and typically goes through a radial or femoral artery and will go to the left side of the heart, where it will then, using interventional radiology, will perfuse the coronary arteries and basically place a stent if necessary. CABG, or coronary artery bypass graft, is an invasive surgical treatment in which cardiothoracic surgery opens up the chest and basically creates a new graft for the coronary vessels to perfuse the heart. And the selection of revascularization strategy should be based on the acuity of the patient's condition, the angiographic characteristics of the culprit lesion, and the complexity of the patient's anatomy, and when appropriate should include a heart team discussion. CABG is preferred for 3-vessel disease, left main disease, 2-vessel disease with proximal LAD stenosis, or ejection fraction less than 50%, or patient with diabetes with 2-vessel disease with involvement of left anterior descending artery. So for the multi-vessel PCI strategies, this depends on the patient status. So if they have STEMI without cardiogenic shock, complete revascularization strategy treating both lesions is shown to decrease the risk of cardiovascular death and myocardial infarction at 3 years. For STEMI or NSTEMI plus cardiogenic shock, you treat the culprit lesion only and can consider to stage complete revascularization, which means that you do the main therapy, treat the culprit lesion, and then wait for the patient to stabilize, and then come back and do the other one. And then you have NSTEMI without cardiogenic shock, in which you have complete revascularization strategy for NSTEMI without cardiogenic shock. Then we have the adjunctive therapy. So this is the medications that you add on top of the revascularization strategy. So at presentation of the myocardial infarction, we want to give these medications, including aspirin for a 325 milligram loading dose and an 81 milligram daily, which is established mortality benefit. You want to do peri-intervention anticoagulation, which is started on the diagnosis of ACS, stopped after PCI if no additional indication. If no PCI and medically managed, discontinue at 48 hours. If there's ECG changes that are improving and concerning for ongoing ischemia has resolved. If chronically on warfarin or DOAC, discuss the transition to short-acting anticoagulation with pharmacy precath. So basically, what does that mean? You start anticoagulation immediately and stop after PCI. You can stop at 48 hours if the ECG shows improvement. And if they're on warfarin or DOAC, you can consider transitioning to a short-acting anticoagulant. So unfractionated heparin is the standard. You start the bolus with GTT, which is basically the drip, and you can use the low intensity PTT goal of 50 to 70. Anti factor 10 protocol is also available. No bolus if giving lytics or if on warfarin and INR less than 2. So basically, you don't give a bolus if patient is on warfarin and INR is less than 2. So low molecular weight heparin can also be used. Fondaparinux can also be used. GP3B2A inhibitors can also be used. Bilirubin argatroban can also be used. Next medication is statin. So 80 milligrams atorvastatin, regardless of baseline LDL, is indicated for all patients at presentation. So the early high-dose statin within 24 to 96 hours may reduce the death and adverse cardiac events if given pre-PCI. The reason being is that it can stabilize the plaque. If the patient has high risk ASCVD with LDL greater than 70, you can add ezetimibe and can consider PCSK9 inhibitor. For nitrates, you give this. This is basically symptomatic treatment. So it helps reduce the pain associated with the myocardial infarction. And you can give sublingual nitroglycerin 0.3 to 0.6 milligrams times 3. And if the patient is refractory to the pain, you could start a drip 5 to 10 micrograms per minute. So the nitropase and GTT have shorter half-life than sublingual nitroglycerin. And there's no mortality benefit with nitrates. It just helps with the pain. But an important thing and a very important thing to know with nitrates is you should not use if you're concerned for inferior myocardial infarction or right-sided myocardial infarction, because this can, or if they also have systolic blood pressure less than 100 or PDE inhibitor use in the last 48 hours. The reason being is that this can cause bradycardia and shock. And if there's refractory chest pain after nitrates, then you want to consider doing cath earlier. Another medication to add is you can consider adding morphine, but this is not recommended, but only if the pain is intolerable. And then NSAIDs that are not aspirin, you should discontinue these because this can increase the risk of bleeding and increases the risk of mortality and reinfarction, heart failure, and myocardial rupture. So adjunctive therapy after PCI or within 24 hours, you want to add a P2Y12 inhibitor. These include ticagrelor, pasugrel, clopidogrel, cangrelor. The main one that you should add is clopidogrel, so that's the one that is most commonly used. Basically, all of these can increase the risk of bleeding. Ticagrelor can increase the symptom of dyspnea, and prasugrel, not too familiar with that, but clopidogrel is the one that's commonly used. And when you add the P2Y12 inhibitor, such as clopidogrel, along with the aspirin, this is called the dual antiplatelet therapy. So the dual antiplatelet therapy duration, so the default length is 12 months. In some patients, one agent P2Y12 inhibitor is non-inferior in reduction of cardiovascular events. So decisions on DAPT should include interventional cardiology. If on long-term anticoagulation, a P2Y12 inhibitor plus DOAC is greater than triple therapy, decreases bleeding, and is non-inferior for ischemic events. So basically, what does this mean? Instead of adding the clopidogrel plus the DOAC plus the aspirin, basically just include the clopidogrel and the DOAC. So the way you do it is you start on triple therapy, including the aspirin for 1 to 4 weeks, and then discontinue the aspirin. So the next medications to add or beta blockers starting within 24 hours. Mortality benefit, you can consider early initiation if ischemic arrhythmias are not are sorry. So you start beta blockers within 24 hours. There is a mortality benefit, and consider early initiation if ischemic arrhythmias are present. And the evidence is controversial, but at this current moment, according to MGH, beta blockers are still indicated. It's not indicated for stable ischemic heart disease status post-cath, but recommended after CABG. Long-term beta blockers status post-MI with left ventricular ejection fraction greater than 50% does not reduce mortality or recurrent MI. There's caution in decompensated heart failure, increased risk for cardiogenic shock. Remember, beta blockers decrease the myocardial oxygen demand by decreasing the heart rate. So this can increase the risk of cardiogenic shock in patients with ischemic heart disease. Contraindications are, as I mentioned, shock, any cocaine-induced MI, PR interval greater than 240 milliseconds, if there's any second or third degree AV block or any severe bronchospasm. Next medication to add after PCI is ACE inhibitors or ARBs. You start within 24 hours in all patients if the blood pressure and renal function is normal. There's a mortality benefit in anterior STEMI. Use angiotensin receptor blockers if intolerant of ACE inhibitors. ARBs are greater than ACE in patients with heart failure or left ventricular ejection fraction less than 40%. And then aldosterone antagonist, this is like spironolactone or eplerenone. So status post-MI on ACE inhibitors and beta blockers and have left ventricular ejection fraction less than 40 or diabetes mellitus or any symptoms of heart failure, you should add these. They do have a mortality benefit. And then the last thing to prescribe is not a medication, but it is a lifestyle change. So you want to advise a patient if they're smoking to stop, to reduce their blood pressure to goals under 130/80, systolic over diastolic. And you want to send them to cardiac rehab. You want to screen them for depression and a flu vaccination. And that is acute coronary syndrome.